Hi, and welcome to our cardiology education series. Today's topic is transforming ECG and cardiac monitoring services at Mayo Clinic and beyond. As we know, the digital revolution is transforming the field and study of cardiology. And this webinar will describe how advancements in AI are driving practice innovation and share our story of our Mayo Clinic transformation. If you have any questions throughout this presentation, please be sure to submit them through the Q&A button under the video screen, and they will be answered at the end of the webinar. I'm your moderator, Tara Gussie, Administrative Leader of our Cardiac Monitoring Practice, and I'm honored to introduce you to Dr. Peter Noseworthy, who will be our guest speaker today. Dr. Noseworthy is a professor of medicine and also leads our cardiac monitoring practice. I have a number of other accolades, but he's much too humble for me to list them off. So with that, I'll introduce you to Dr. Noseworthy. Thanks so much for joining, and we're looking forward to hearing from you.
Great. Well, thank you very much, Tara, for the opportunity to speak and join you all today. I'm excited to talk to you about what we're doing in the ECG lab and with cardiac monitoring more broadly. So I should mention that a lot of the work that we've done is funded by a variety of different grants, some of them internal, some of them external through NIH. Some of the technology that I'll talk about has been disclosed or patented, and some of it has even been licensed. So I'll try to make mention of that as I go so you can understand the context. I have been in this role in the ECG lab for about 5 years or so. And one of the early realizations that we had when I took over this role was that because everything is so centralized at Mayo and we have such archived data, high quality digital form, and then very well labeled by cardiologists over decades, really, we had the makings of what we needed to apply artificial intelligence to this data set. And at first, we didn't know how this was going to work, but over the last several years, we've really seen an explosion in our ability to apply these technologies to ECG data. And I think some of the findings have been really interesting. And I think it'll likely change the way we look at ECG data in the future. I'll try to give you some examples of that. So on the first day that I took over my role, I had an ECG done in the ECG lab, and I had it read by one of our most experienced cardiologists. It was read as normal sinus rhythm, sinus arrhythmia, normal ECG. And of course, this is reassuring. It's nice to know that you have a normal ECG, particularly on the first day of taking over a new job, but it doesn't really inform me in terms of my health in any meaningful way, binary, normal, abnormal. And unless I was having an MI or I was in atrial fibrillation or something, there's not much information to be gleaned from this otherwise normal ECG. But that's really changed. And what we've realized is that there are a lot of signals hidden within these data modalities that we can unlock with AI technologies. And let me show you how we look at an ECG now. So if you went into my Epic chart, this is my chart of de-identified or stripped of anything too interesting. But if you click here under the results viewer tab and bring up cardiology, what we've done is created this separate viewer at Mayo Clinic called the AI-ECG Dashboard. And what it does is opens up a separate viewer, and then all of the AI models that we've developed over the past several years are then run on all of the ECG data that are available for that individual patient with a single sign-in. So it's created this very interactive dashboard for people to explore these kinds of data. And you recall my ECG basically said normal ECG, but when we look at the AI models, you can see that it estimated my age to be 37. At the time, I was 39 when I had my ECG done. So really incredible precision. A lot of us on the call read ECGs all the time, and we might be able to say, well, this person is generally healthy or they look a little bit older. But to be able to say within a few years what the likely age of that patient is really remarkable and proof, I think, of the concept that there are signals there that are essentially hidden in plain sight. It could say with 98 probability that I was a man, but of course, we don't need the ECG to say male or female or to say what our age is. But for medical conditions like, what's my ejection fraction? It estimates it at 58%. What's the probability that I have a low ejection fraction is very small, and then all the way down the line. So what's the likelihood that I have undetected atrial fibrillation or hypertrophic cardiomyopathy or aortic stenosis or cardiac amyloidosis? And the list goes on, but we can now take this test and use it as a tool essentially to risk stratify for any number of diseases. Now, I was fortunate in that my ECG was relatively normal, and I didn't discover with AI that I had any major health problems. But take, for instance, a different patient, another young man, 35 years old. He came to the attention of cardiologists at Mayo because his sister died suddenly and unexpectedly. And they really couldn't sort out what had caused her death. He came for cardiac evaluation. ECG was read as basically normal. A really astute viewer might say maybe the R wave progression's a little bit poor, but overall this was read as a normal study. But the AI models actually said that she had a 76% probability of having, or he had a probability of low ejection fraction. And when he went on to get an echocardiogram, indeed his ejection fraction was 18%, really in a dramatically low range. And this family went on to be diagnosed with a familial cardiomyopathy, and other family members were treated. And hopefully that second potentially catastrophic event, like a sudden cardiac death, could be averted for the family members. But what about applying this to the general population, and can these things be scaled? Those are the things that I'd like to try to explore with you over the course of basically the next hour or so. So taking a step back, when we think about applying AI models to ECG, I think of it as, or really in medicine in general, falling into one of two categories. Either we can try to use AI to streamline human capability. So do what a cardiologist does, or do what an ECG tech does, just do it faster and more consistently and at scale. And then the second thing is to really see beyond what a human can see. And this is that sort of crystal ball thing that I'm trying to demonstrate in these opening few slides. But it's very possible that the AI can see things that even an experienced cardiologist may not be able to discern from the ECG. So the idea behind scaling human capability is at Mayo Clinic, we maybe read 250,000 ECGs or more per year with a team of about 100 technologists who perform and interpret those tests. If we could apply AI, we could make the job of those techs easier. We could scale what we do, and potentially we could offer our services more broadly than just within the walls of Mayo Clinic. And then the idea about seeing beyond human capability is the idea that we can bring new value to an ECG. So the ECG has been around forever, relatively unchanged, but we can unlock a lot of hidden potential with AI. So talking first about doing human ECG interpretations, essentially, can it read an ECG the way a tech or a cardiologist would do? That was really our first task when we started to train AI on the ECG, and it took sort of an iterative series of experiments until we got something that was working fairly well. We use a technology called convolutional neural networks, and that's the same sort of technology that is used in facial recognition software. So if you were training a computer in 1975 to recognize a face, you might say brown eyes, brown hair, this color skin, this sort of shape of the face. And you could make a sort of a scoring system and pair those up with individual people. But what a convolutional neural network does is it takes those images and it breaks it into minor features that may not necessarily be discernible to the human eye. Things like border zones and curvatures and relationships between structures. And then it weights all of those components and it comes up with a model that can be much more powerfully predictive. And if you think about the way your phone can recognize pictures of your kids, even if they're in their Halloween costumes and even if they've got face paint on for the Vikings game, it's really very remarkable. It's seeing things that are not necessarily obvious to the human eye. So we use those convolutional neural networks to train models to pick up each of the codes that we apply to ECGs, so left atrial enlargement, left ventricular hypertrophy, whatever it might be. The problem with doing that, though, is we created models that gave us tons of outputs. So it would over-label an ECG because it would see all kinds of patterns, and it wouldn't recognize the associations between these patterns the way a cardiologist would. So the next layer was to try to teach it to learn those associations. And eventually, through an iterative process, we came up with something that looks relatively human-like. And then the next innovation was to use what's called the transformer layer. The terms aren't really that important, but essentially to take all of that information and then translate it to a sentence that reads like the way we communicate about ECG. So it strings it out into logical order with all the connecting words until it sounds like a human reading an ECG. So we test computer AI models using something called the Turing Test. And probably many of you on the call are aware of this, but the concept is AI models are black boxes. But if you put a piece of input into a black box and you get something back and you can't tell if you gave it to the black box or you gave it to a cardiologist, then it's passing that test in terms of looking like an intelligent program. So we tried to do that for cardiology, for these ECG interpretations. And we compared the ability to read to the standard computer reads through the GE Marquette cart, the AI read that we generated, and then a final read from an experienced cardiologist. And what we found is that it works pretty well. We get it right about 94% of the time, and we get something that looks exactly like what the cardiologist said about 85% of the time. So it's good, but it's not perfect. Of course, there's a bit of an art to ECG interpretation, and it may be that we're going to eventually reach a ceiling. But it's possible that these models then can help us scale what we do, make the tech's job easier, perhaps help us find the needle in the haystack that might occasionally slip through our detection. And we hope to be able to deploy these models for those purposes. But I think much more interesting is when AI can see more than a human can see. And I showed you a little bit about that in the opening slides, but let me dive a little bit more deeply into 3 examples. So the first is low ejection fraction. For people who are not cardiologists on the call, ejection fraction is the fraction of blood that pumps into the heart that is pumped out of the heart with each beat. So if it's over 50%, that's within the normal range. But if it doesn't pump all the blood that it's getting out, that's a sign of a weak heart muscle, and it can cause heart failure and symptoms and so forth. So we do want to know when the heart is failing. We typically use an echocardiogram or an ultrasound test to actually look at that squeeze of the heart and look at that function. But we believe that there might be enough in the electrical signal that we can identify low ejection fraction. So what we did is we paired the ECG database to the echo database, and we used a convolutional neural network again to pick up features on the ECG that correlated well with low ejection fraction on echocardiogram. And the test performed very well. So we measure the performance of a test by the area under the receiver operator curve here. If it's a poor test, it's just like a coin flip. And you get this dotted line here at unity, and the area under the curve is 0.5 of the total area. That's a coin flip. A perfect test is perfectly specific and perfectly sensitive. So it fills all of this in and it would be 1.0. But this test was 0.93, which really is quite excellent. For comparison, tests that we use all the time in routine clinical practice, like a mammogram or a PSA for prostate cancer or a pap smear, whatever it might be, typically have an AUC of around 0.8, maybe 0.75. So already, just on the ECG, for an indication that it was not intended to be used for, actually performs better than tests we use all the time in routine clinical practice. We then went on to do a number of experiments to validate this in other populations, because of course it's one thing to show that it works well at Mayo Clinic and our data set performed on our machines and our population, quite another to show that it works more broadly around the world in diverse data sets and off different ECG carts, for instance. Also, we have to be mindful of the fact that a model that is derived in one population, racial or ethnic group, may not perform well in other groups. And one of the Achilles heel of Mayo Clinic data is that it represents only the patients, at least in Mayo Clinic, in Rochester, in the upper Midwest. It tends to underrepresent other racial and ethnic groups that are very important for these models if we were to generalize them more broadly. We were glad to see that the performance was remarkably consistent across a range of racial and ethnic groups, giving us some confidence that we might be able to use this model clinically and test it prospectively. I'll take a step away from this just for a moment because I think this tells sort of a cool story, but an AUC of 0.93 is excellent. And early days when we were developing these things, we thought, what if we simply added age and sex to the model? Would it be a perfect test? Would the AUC go up to 1.0? And could we get rid of echocardiograms altogether? So when we added age and sex to the model, it actually did not improve its performance at all, which for somebody like me was a head scratcher. But for the AI engineers who actually developed these models, the answer was obvious to them. And the answer was that by telling the model the age and the sex of the patient, you weren't giving it any information, any new information, because it already knew everything it needed to know about age and sex simply by looking at the ECG. So they proved that to us by then training a model for sex, and the AUC here is just off the chart, 0.97. It's almost always right. And the relationship between AI-ECG age and chronologic age is relatively strong. It's not perfect, but this, of course, has spurred all kinds of other interesting questions, like, this is such a good test that when it fails, it's probably telling us something about the ECG. So much so, actually, that on our dashboard, if there's a mismatch between the patient sex and the ECG sex, we actually disregard the other AI models, because it could mean that the leads weren't placed right, or that there's too much noise on the signal, or that there was something unique enough about that patient's ECG that the other models are unlikely to work well. Similarly, it's not a perfectly one-to-one correlation, but there's clearly a correlation here. And then there's variation within each age. So is this actually telling us something about physiologic rather than chronologic age? And if that's the case, could we use the AI-ECG as a way of getting at comorbidity or frailty or some other measure? Could this be of use in triaging patients for surgeries or other type of procedures, or even just prognostically? When we started to dive into individual patients, we saw some very interesting cases. My colleague Suraj Kappa was doing a case review, and he found this outlier who was aging at a normal rate, but then seemingly overnight became younger. And he was curious what happened. Did something change with this ECG? Did the patient get a pacemaker? What happened? When he dove into the chart, what he found actually was that this patient had a heart transplant and got the heart of a younger man. And indeed, this was reflected on the ECG. So, anecdotal, but pretty cool to say even it can even know the age of your transplanted heart, which we thought was a lot of fun. There's a condition called hypertrophic cardiomyopathy. Many of you on the call probably know about this, but for those of you who don't, this is the condition where the heart muscle thickens and the heart becomes sort of muscle bound, and it can cause arrhythmias and cause you to have syncope, passing out. It's the reason that sometimes a basketball player may drop dead on the basketball court or on the soccer pitch. So it's a condition that we would like to be able to screen for. But the problem is the ECGs are often abnormal, but they can be abnormal in many different ways. There can be high voltage, there can be T-wave inversions, there can be Q waves, there can be any number of things. And there's no single pathognomonic abnormality that tells us this patient has hypertrophic cardiomyopathy. So there's a fair amount of controversy in our field about whether we should use ECG at all to screen for this condition. But Mayo Clinic is a very large HCM referral population. We do a lot of septal myectomies, and people like Rick Shimura, Steve Ahman, others have built big practices around the care of these patients. So we have at least 3,000 very well characterized hypertrophic cardiomyopathy patients. We then created age and sex matched controls, and again used a convolutional neural network to train the model to pick up the ECG features that are consistent with hypertrophic cardiomyopathy. Every time we do these models, I'll point out we divide the population into three groups, two groups to sort of derive and then internally test and find the best model, and then a separate untouched testing group to really validate it and make sure that it actually works, and we're not just creating an overtuned or overfit model. So the results are actually just on this portion in the testing group. This model works extremely well. So the AUC here is similar to the sex model with an AUC of 0.96. It really works very well for detection of hypertrophic cardiomyopathy. And furthermore, you see that there's very good separation between a positive and a negative test. So it's pretty sure it's normal when it's normal, and it's pretty sure it's abnormal when it's abnormal. So we think that this might actually be something that could be used for screening. And my colleague, Kostas Siontis, and a few others are working on building out programs around implementing and testing these models further. Shortly after we developed this model, I was rotating on the clinical service, and I was asked to see a patient, a 25-year-old woman who was admitted for a septal myectomy. So she had one of these muscle-bound hearts, very sick septum, and one of our surgeons was going to go in and actually resect the septum so that it would relieve some of that obstruction. And her ECG, you hear a trend here, but it was actually read as a normal ECG. There's a little bit of abnormality here in V2. The right precordial leads have this T-wave inversion, but it was passed by the cardiologist reading ECGs for the day. But actually, our model said that she had a 72% probability of having this very rare condition, hypertrophic cardiomyopathy. It only affects 1 in 200 to 1 in 500 people. So, if you think about a diagnostic odds ratio, that's really through the roof. Amazingly, when I saw her the day after her surgery, her ECG looked, to me, even a little bit more abnormal. You can see the QRS is fractionated, the ST segments are elevated, but to the model, it looked less like hypertrophic cardiomyopathy, sort of proof that taking a heart with all this abnormal heart muscle, cutting some of it out, actually made the heart look less pathognomonic or less characteristic of hypertrophic cardiomyopathy, even though to the eye of a cardiologist, it looked a little bit more abnormal in the post-surgical state. The third example I'll talk about is atrial fibrillation. Very common condition, that it can be very fleeting, it can be hard to diagnose, it can even be asymptomatic. So there are a lot of people out there with subclinical, undiagnosed atrial fibrillation, and the problem is it can cause a stroke. So stroke is actually not an uncommon first presentation for atrial fibrillation, but we would love to be able to find those patients and get them the treatment they need and hopefully prevent them from having a stroke. And we need better ways to do it. We do things like implant loop recorders, which are costly and relatively invasive, and we might do serial cardiac monitoring. But what if we could use a single ECG to stratify a population in terms of risk of atrial fibrillation? So the model is the same. We take a group of patients who have had AFib and normal sinus rhythm and a group that have only had normal sinus rhythm. We train a model to pick up the features which are present in normal sinus rhythm, which indicate likelihood of concomitant atrial fibrillation. And I think this is a much harder task. It's a more subtle ask of one of these models, but it still performs pretty well with AUCs that approach 0.9. Clearly better than just asking what's your age and do you have risk factors for AFib. We then worked with some colleagues in neurology who maintain the Mayo Clinic study of aging. Many of you may have heard of that. That's the study that looks at Alzheimer's, and patients are really well characterized over decades, and they have serial ECGs and serial echoes and Holter monitors. And as a result, if they develop atrial fibrillation over that time, we know when they developed AFib. We know it's incident, not prevalent atrial fibrillation. So we looked back at the baseline ECG, and the model was able to stratify pretty well in terms of the risk of incident atrial fibrillation, such that a model output of about 0.5 translates to about a 25% risk at 2 years and 50% at 10 years. Just as good or better than most of the clinical risk schemes. Now, Alejandro Robinstein, one of the neurologists, stroke neurologists and colleagues of ours, came to us with a difficult patient. He'd been following this patient for a long time. He first met her in 2014 when she was admitted with a stroke. And he looked for AFib because to him it looked like an AFib-related stroke. It was multiple vascular distributions, presumably cardioembolic, but Holter monitor didn't demonstrate any AFib. She was in normal sinus rhythm in the hospital and on telemetry. She had no symptoms of AFib, so he couldn't anticoagulate her. She then came back in late 2019 with another stroke, and this one actually sadly quite devastating. And she was still in normal sinus rhythm. And then about 2 weeks later, she actually developed atrial fib and atrial flutter. And it was clear probably that rhythm had underlied both of these strokes, or at least that was the hypothesis. And if we look back at her ECGs over the years, this is the AI output on the y-axis and time on the x-axis. If you go back 12 years before her first stroke, she'd already crossed over this threshold, at which point we think somebody would be at elevated risk. So it's possible that she could have been screened for AFib maybe 10 years before her first stroke, or maybe her risk was so high here in 2014 that we could have prevented the second stroke by empirically anticoagulating. Of course, that's all conjecture, and we need randomized trials to demonstrate that. But these are the kinds of ideas that I think get brought to the fore by these kinds of studies. So about a year ago, actually, Nature Medicine published a issue in which they issued a call to researchers in the AI field to not just derive these models and publish them, but actually hold them to the same standard that we hold other diagnostic tests and therapeutic interventions. And we need to have randomized prospective trials. Otherwise, these are kind of party tricks, and they need to be held to the same level of rigor. in parallel with this, we were actually working on our first randomized trial that was testing these sorts of algorithms. It was called the EAGLE study, which is, ECG AI-guided detection of low ejection fraction or something along those lines. What we did is we leveraged the Mayo Clinic health system across the upper Midwest, and we worked with primary care doctors who generally deliver care in care teams where they cross-cover each other and they sort of share a panel of patients. And we were able to cluster randomize entire care teams to either get the AI or have usual care. So there were 120 care teams. Half of them got access to this AI result, and half of them had usual care. And then we followed these patients to see, were they diagnosed with new low ejection fraction? How were patients treated? And what was it like to be a part of the study as a patient and a doctor? How do sort of man and machine come together? Is AI useful or is it just irritating? We wanted to know from the people who are actually using it clinically. We communicated the results of the AI through Epic. So this is a de-identified screenshot of a patient. And if they were in the trial and you went into the document viewer to look at an ECG, you would get this PDF for the EAGLE trial. And it would say the result was either positive or negative. And it would link to the original publication. And it would link to an Ask Mayo expert, which is sort of like our internal up-to-date, which would tell them what to do with an asymptomatic left ventricular dysfunction. And we enrolled over about 6 months or so, about 22,000 patients in the study. They're split evenly between the intervention and usual care. And what's important here is that these were patients being seen in primary care across the upper Midwest. About half of them were in rural health clinics. So we weren't testing this in cardiologists who have already drunk the Kool-Aid and love AI. These are frontline clinicians taking care of patients who have to basically take these results, act on them, and integrate it into their clinical practice. Most of the ECGs were done in the outpatient setting, although we did include hospital and emergency room ECGs as well. Our primary finding was that the intervention, so just flipping it on in Epic, increased the diagnosis of low ejection fraction by about 30%. So it's still relatively rare. Only 1.6% of control patients were found to have previously unrecognized low ejection fraction, but 2.1% in the intervention arm. And probably equally important is that we didn't demonstrate a significant increase in overall echo utilization. So even though patients got the results, they were told to get an echo if there was low EF, they used their discretion. We only increased the echo utilization by about 12% or something in the intervention arm, and overall it was non-significant. And only 6% of patients even had an alert in the first point. So it was a relatively small impact on clinical practice. It performed well across a range of subgroups, but I'll just draw your attention to this. It seems to work really well in the outpatient clinic. And probably the reason is that's a little bit more of a resource-constrained environment. Whereas if you're in the hospital and you have any symptoms whatsoever of low ejection fraction, you'll probably get an echocardiogram. Whereas in the outpatient setting, especially when clinicians are watching the per member per month kind of expenditures, and they're very cognizant of out-of-pocket expenses and what's going to hit the patient's pocketbook, they don't want to unnecessarily order tests. So it works particularly well in guiding treatment when there's relative constraint on resource allocation. Also, I want to draw your attention to the fact that if a low ejection fraction was diagnosed, the vast majority of patients were treated appropriately with an ACE inhibitor or beta blocker. So hopefully these patients are actually getting earlier treatment and either their EF gets better or we don't see further decline in LV function. So now I'll move on to atrial fibrillation. I'd like to know if that AI model for atrial fibrillation could be used as a screening test. And those of you who are in primary care probably are already aware that most guidelines don't recommend screening for atrial fibrillation in unselected patients. Even though it's common, even though it's detectable, even though it's treatable, nobody's ever demonstrated that treating screen-detected atrial fibrillation is cost-effective or that it reduces stroke. So we really don't have strong enough evidence yet to justify that. So I think of this as a continuum of evidence. We have the general population, I've already shown you that the ECG can stratify that general population into a group that's at risk. But the next question is, what do we do with that? Can we monitor these patients and actually detect atrial fibrillation? And then, of course, the next question after that is, if we've detected it, should we treat it, and can we prevent a stroke? So until we build out this continuum of evidence, we're really not at a point where we can recommend widespread screening for atrial fibrillation. The way this study worked is we wanted to automate this as much as possible and take a very pragmatic approach to deploying the study. So what we did is we started by running the AI on every ECG that was done at Mayo Clinic over a year. And we characterized every single patient. I think in the end of the study, it was actually over a year. I think we ran the AI on 400,000 ECGs. We then identified patients across a broad spectrum of AI risk. And then we went into the medical record with natural language processing, as well as structured data, to scan for patients who looked like they could be eligible for a study like this. And they had to be in a sweet spot. So if they were really low risk, if they were 25 years old and had no risk factors, detecting atrial fibrillation won't be useful because we would never treat that. Similarly, if they were already on a blood thinner, or they already had an indication for a blood thinner, or they'd already had major intracranial bleeds, and we wouldn't want to start them on a blood thinner, we wanted to exclude those patients. So we wanted to find patients who were in that narrow band. And we used a combination of structured data from the chart, as well as natural language processing, to identify those patients. And once we had a group of patients, we sent push notifications through the portal. So patients who had already said they were interested in research at Mayo Clinic got alerts through their portal that said, would you like to be a part of an AFib screening test or a study? And we wanted to have low risk and high risk. So just telling them that didn't tell them anything about their risk, just that we wanted them to participate in the study. They actually could consent through the portal without traveling and talking to a study coordinator or one of our nursing staff or one of our doctors. They could do all this from the comfort of their own home. And we ended up enrolling 1,000 patients to do cardiac monitoring. The monitor that we used is what we now use for routine Holter event monitoring and MCT, or mobile telemetry, at Mayo Clinic. It's a device that has 3 leads like this, but it gives us very high fidelity clinical grade signals because it's leaded, and actually gives us all the inferior leads of a 12-lead ECG. We mailed them this device. It transmits to us through real-time cellular connection. So if they have AFib at 11 o'clock in the morning, by midday, we know about it. And I was on the phone telling them about their atrial fibrillation and trying to make a decision about how they might want to be treated. I'll give you an example of a patient who enrolled in this study. He was a retired Mayo Clinic doctor, actually, who had each of these dots represents an ECG that he had done at Mayo Clinic. All of them were normal sinus rhythm, but you can see for 15 years or more, really, his ECGs were starting to cross that threshold in terms of being high risk of AFib. And he had never been diagnosed with AFib. He even had a Holter here or there. But shortly after we hooked him up with this monitor, we indeed identified atrial fibrillation, and he went on anticoagulation. And to him, that was quite a big intervention. Hopefully, that's somebody who we might have prevented from having a stroke. Another patient enrolled in the trial and actually ended up talking to a reporter at Stat News, and they did a sort of a piece on him. And I think this is a nice story because it takes a very balanced approach. What are the costs? What are the downside of this kind of screening approach? How should we be enthusiastic, and where might we be cautious about doing these kinds of things? So I'd encourage you to read that if you want to hear more about it. We've now fully enrolled this study, and we've enrolled patients from 40 different states. And it's important to keep in mind that none of these patients actually traveled to Mayo Clinic. They're, of course, clustered in Minnesota, Arizona, and Florida, but we have patients from all over the place. So I was making phone calls to patients, in Wyoming, and saying, we found you had AFib, and they never left the comfort of their own home. It was very interesting. That study is currently being analyzed, and we hope to have it published, I would hope, within the next year. But the methods of the study have already been published and are already in the public record, so that's why I'm sharing that today. The other way to translate these kinds of technologies to practice is to get the technology to run on various form factors that sit in patients' pockets or in a clinician's stethoscope. And there are a number of opportunities to do that. Probably the easiest one is to deploy it in the electronic health record, and I've already shown you that. where we now have an AI dashboard at Mayo Clinic. So any clinician can look at anybody's ECGs and run it automatically through all of these AI models, and it'll give them a sense of what the model is showing and put it in the context of their other ECGs. So I showed you mine, but I've only had one ECG done. This patient actually has had, dozens of ECGs. In 2003, the patient had heart failure and actually underwent a heart transplant. And you can see an abrupt improvement in their heart function based on their ECG. They did well all the way until almost 2020, when again it popped up as an abnormal test, and indeed they had rejection of the transplanted organ at that time. So a whole nother group, a group in Florida, as well as some of the transplant cardiologists in Rochester, are working on refining the model for cardiac rejection. But this was sort of a hypothesis-generating observation that it might work well for that application. There's a company called Echo who make a stethoscope that has two metal plates and it has a microphone. And their innovation was that people listen to heart sounds, but it's hard to communicate and teach it. So this actually allows you to record heart sounds on a smartphone, and then on rounds, doctors can compare the heart sounds. You can compare them over time. You can even look at a phonocardiogram and then time it to the single lead ECG that's generated from those two metal plates. But some other researchers, not me, but a few others at Mayo, actually have IP on the low ejection fraction algorithm and licensed it to this company because we wanted to see if we could actually deploy the model in a clinician's stethoscope and use the stethoscope then as a screening test for low ejection fraction, which would greatly increase the power of the sort of a simple bedside diagnostic test like that. So I think we all know that in medicine in general, patients do best when we leverage expertise from a diverse group of clinicians and folks. So we know that when we get surgery and anesthesia, cardiology, social work, nursing, everybody working together, we really can do everything we can do for an individual patient. But I would say over the past couple of years, what we've really found at Mayo Clinic is that there's room at this table for an entirely new member of the healthcare team, an AI engineer or a data scientist. And Paul Friedman, our chair, has really championed this idea. We now have 6 data scientists working within cardiology and many, many clinicians working across many different projects. And the data scientists have helped us look at things that have been right in front of our noses all this time, but look at it with fresh eyes, apply new technologies, expand our capabilities, and I think help us provide very good care for our patients. So I hope what you've been able to see in this talk is that these kinds of technologies are now starting to be useful in clinical medicine. They have clinical utility. They can be interdigitated into complex clinical workflows. They can predict and detect disease. They can be massively scalable once they're in the electronic health record or once they're in your pocket on a smartphone or a stethoscope. And in working with these folks, I think we've been able to drive innovation at Mayo Clinic. So I'd love to take a few questions if we have some time. Thank you very much for the opportunity to speak.
Absolutely. So there's several questions in the chat. So looking forward to kind of getting your perspective on this. So Dr. Noseworthy, when you spoke about the EF measurements by Echo, a question on what was used as the gold standard as you looked at that research?
The gold standard in that study was the Echo assessment of ejection fraction using the Simpsons method with biplane. So that's a rigorous way to assess objectively left ventricular ejection fraction. Others have said, why don't we use MRI? But the reason we didn't use MRI is there's a little bit, the patients who have both ECG and MRI are probably different than patients who undergo an echocardiogram. There are many reasons to get an echo. So there are more normal people getting an echo than there are normal hearts getting an MRI. And we want to make sure that the models that we derive are as broadly applicable as possible. So that was our best assessment. And we just have a huge echo data set, so it helped us do that.
The next question coming in, were all the ECGs used 12 lead ECGs?
Yes, so it's still, we've been doing this now for a few years, but it's still early days. We're building out capabilities to look at imaging data, echo, MR, CT, look at the electronic health record in ways that apply AI. But a lot of the work we've done, just because it's such a tractable problem, is using the 12-lead ECG. And our main data scientist, Dr. Attia, started in that field, and really a lot of the work that he's done has sort of come out of the early work that he led. Now, implicit in that question is probably, does it work on a single lead ECG? And we found that for many of these models, it actually does work very well. So some of you may have smartphones or smart watches that perform an ECG. And what we have found is that we can take a 12-lead model and we can condense it to a single lead. Usually there's a bit of a diagnostic hit when we do that, but model performance may drop slightly, but not dramatically, at least for some of the models. There may be reasons then to further tune the model for that kind of a form factor for a single lead recording, but that's all work that's ongoing, and the data team is working hard on those kinds of questions.
And for those of you as well listening in, make sure to drop any questions within that Q&A feature within the chat section. Dr. Noseworthy, a lot of fascination around how in the world can this ECG AI derive my sex, my age, familial conditions. Can you speak to a little bit more on how does it actually work? How do you feed the data? Do you tell it what to look for, what not to look for? Just kind of elaborate, because I think people in the chat are blown away at some of the capabilities.
Yeah, it's almost spooky, isn't it? It's sort of, I almost was afraid to know what it was going to say when I ran my ECG through the AI. What if it said I was 25 years older than I was? What does that mean? Would it keep me up at night? And there's a bit of danger there. Your question is basically, can we peer inside that black box? So I talked about the Turing Test and how you put an input into a black box, you get something back. And that's a whole field of data science. One of our engineers actually did his PhD in that. And it's a really interesting topic. So I will give you a clinician's version of what I understand about that work. But it's, of course, computationally very interesting and complicated, and I'll probably even butcher some of the terms. But there are a number of ways we can try to tell what the AI model is looking at. The simplest is to do an attentional map or a saliency map. So you give it a single piece of data, a single ECG, and it can tell you along a squiggly line, which is a sort of a linear time series data, which pieces along that time series are contributing most. But it tells you that for one ECG. Then you can then average it over many ECGs. But unfortunately, what you see is that for the low ejection fraction model, it's kind of the P and the PR interval and the QRS and the T wave, as in it's kind of the whole ECG. It's not the TP segment, but that's not all that informative. Another way you can do it is you can alter the input and then start to see when the output starts to fail. So you could take an ECG and you can tweak it in some way. So you could erase all the P waves and put it in and say, does it still work? And if it's not working, it tells you that the P waves were important. So people have done a little bit of that where you blind the model to various parts to figure out what's contributing most. There's a cool idea where you can actually train a different model, not to read the ECG, but to create an ECG. So instead of the output becomes an input. So the output for one model is the input for the next model. And you create this circular system where you get a fake ECG that's fed to a model, it spits something out, and then based on what it spits out, it goes back in, it creates a new output until what you create is like a caricature or a quintessential version of whatever you're looking for. And it's called a generative adversarial network. It's generative because it's creating something, and adversarial because it's like two networks against each other. At least I think that's what it means. But if you can Google that, and you'll see some fun examples where it'll, it might try to create like an ideal face, and it'll create faces that are totally new, but they look to you and me like a human face. There are also other examples where I've seen one of a zebra, and because it's trying to create the quintessential zebra, it doesn't know that a zebra's head should be here and its feet should be here. It just creates a mashup of mane and stripes and a signpost from the zoo and a bit of savanna, and that's sort of zebra to the model. So it depends on how the model is trained, what it's seeing. But it's kind of fun to think about what it's like to peer into those sort of things. I'd love it if a model could teach us to read ECGs better, and that's probably also part of your question. Because if it could teach me to recognize age and sex by ECG, I'd love to know that and go around and do that at parties. But it's we haven't really figured out a way to have the AI teach us yet. But why not? It would be great if we could unlock some of that capability.
No, that's great. Fascinating for sure. A few other questions here coming in the chat. So what was considered low EF? Was there a certain percentile used?
Yeah, we train it as a binary classifier. So that's also a good question. So we actually did low EF or not low EF, rather than those of you who watch Silicon Valley will know hot dog, not hot dog. But those of you who don't are just rolling your eyes right now. But it's a much simpler problem to do a binary classifier like that. So we picked an ejection fraction of 35% because below 35%, you might start to think about putting in a defibrillator, and guidelines would recommend various treatments. So that was sort of our line in the sand. You then create a model that has a continuous output between 0 and 1, and that correlates pretty well with a continuous ejection fraction as a number. But the model performance, an AUC, is always for a binary test. Is it male or female? Is it low EF or is it normal? Is it hypertrophic cardiomyopathy or not? AFib or not? That's why it's more like a coin flip rather than just a correlation in a scatter plot.
Fascinating. I think this leads into this next question. Clearly, you're passionate and an expert about this. How long have you been studying this type of work, or really kind of working on some of these new and novel AI functionalities?
Yeah, I'm an electrophysiologist, cardiologist. I do ablations and see patients, and I direct the medical director for the ECG lab. Not an engineer. I'm not a mathematician. I'm not a data scientist. I'm not a computer scientist. So I get to talk about all this great stuff, and it's great fun for me. But the real science of it is being done by a data science team who are really expert. And we have essentially completely non-overlapping skills. So people like me and my colleagues in cardiology, and there are probably a dozen of us whose work was represented in the talk that I gave today, we try to say, what are the key questions we want to answer? How should we apply this? How do we design a dashboard? How do we test this in a trial? How do we communicate results to patients? What's the next question? Those are the sorts of things that keep me up at night. And the science of it, although I try to read about it and learn about it, is really very much delegated to the experts on this. Occasionally, I'll meet a cardiologist who can code in Python, but they're a rare bird. And it's definitely not me.
That's really super helpful. And I would give you a lot more kudos for that than that. You kind of deploy and make it all happen here within the walls of Mayo Clinic, which has been pretty fascinating. Another question coming in is, when do you see some of these new and novel enhancements being available outside the walls of Mayo Clinic?
Yeah, I get that question a lot. I'd love it if this was just available to everybody. Now, but it would be like unleashing a Pandora's box, and you can imagine where these things could fail. But it will eventually get there. I realized my talk was pretty sunny in terms of things working out. I have other slides about some of our colossal failures, and I must have hidden them in a sort of fit of optimism when I was putting together the slide. But for instance, we took the AFib algorithm and we tried to predict postoperative AFib. It didn't work at all. It was almost useless. So even though you think it would work for that kind of a application, it didn't at all. So we need to do due diligence to figure out where it works, where it doesn't work, and define very clear guardrails for how to apply these kinds of things. We need very narrow intended use, and then we need to take that to FDA in order to have FDA endorse the use of these more broadly. Right now, we have a couple models that are at FDA, or at least in pre-submission and in early days of going through that. Mayo has formed or has helped form a portfolio company that actually handles some of that regulatory work. And as that gets more mature and these things are approved, we'll figure out how they can be deployed in various clinical practices. And that's really, you think about it along a stepwise continuum. There's, cool, we can derive a model. Cool, it seems to be generalizable. Oh, this is how we can actually apply it. This is how we can get it into clinical workflows. This is how we can get it for broad, widespread use in routine practice around the world. And we're not there yet, but that's definitely the prize and the the goal that we're all trying to go after.
All right, a few others here in the chat. You had mentioned, Dr. Noseworthy, a study related to ECG AI risk and as it relates to atrial fibrillation. Where was that published, and can you speak a little bit more about that particular publication?
The atrial fibrillation paper was published in Lancet, which is a British journal. That's one of the major medicine journals. I tried to put the journal and the year in the lower corner of most of these slides. So that one was published in Lancet. The next study that was the prospective study design was in American Heart Journal. And then we probably have 4 or 5 other papers on that algorithm for various applications, including the Mayo Clinic study of aging, some cardio-oncology applications, the post-op cardiac surgery. You can find those, I think, online with my last name, AI, and AFib.
Sure.
With maybe Friedman or Zaki Attia would be other authors.
Wonderful. More questions coming in a little bit about kind of seeing some of these services beyond the walls of Mayo Clinic, as kind of the presentation indicated. Aside from the AI, are there other technologies that Mayo Clinic is offering related to cardiac monitoring?
You know, I was actually going to focus a little bit more on that on this talk, but it just seemed like there was so much to talk about with AI that I focused today on AI. But that same device that I showed you for that patient who was a retired Mayo Clinic doctor who we identified having AFib, we're now using that for all of our heart monitoring at Mayo. And we like it because it has high quality signals, it has cellular connection and real-time full disclosure for our techs. We have actually are just now starting to offer that externally. So you could, if you're interested in cardiac monitoring with these devices, we can actually provide those services. And the economies of scale that we have at Mayo in terms of the logistics of sending these devices back and forth, making the phone calls to the patients, telling them how to put it on, dealing with the data ingestion, creating reports, dealing with urgent results, we can take care of all of that for your practice. So we're just now starting to offer that as an external service. Just very similar to the way you might order an esoteric lab test through Mayo. We can do that now for cardiac monitoring. And especially for mobile telemetry, I think a lot of practices around the country are struggling to find essentially a good vendor for cardiac monitoring, cardiac telemetry, but we'd love to partner with people to do that.
Few other questions just as we're kind of wrapping things up here. So as it relates to different new and novel AI capabilities, are there other disease detection that you are actively studying as it relates to CAD or other type of cardiac diagnoses?
Yeah. So you can imagine this started with just a handful of people with doing low ejection fraction, AFib, and things. There are so many of us now at Mayo in cardiology working on these things. So, you know, there are groups working on pulmonary hypertension, various valvular heart disease, coronary artery disease, various myocardial infarctions, chest pain syndromes. The list goes on, such that we've had to hire many more data scientists, and we really have more questions than we have time in the day to answer them. So we have a system of trying to prioritize them, and whole groups of people outside of me working on many different questions. We've even shown that we can detect non-cardiac conditions with the ECG. So we had a recent publication on cirrhosis, and you can imagine cirrhosis causes electrolyte abnormalities and fluid shifts. Some of that is reflected on the ECG, and we can actually detect some signs of cirrhosis on the ECG. So there may even be some non-cardiac diseases that we're able to pick up with a cardiac test, which is sort of a cool concept.
Quite a few questions related to any vendors that we work with to integrate AI models. Are there certain platforms or vendor relationships that we're actively collaborating with?
Yes. Well, I did show the one with ECO for the low ejection fraction algorithm, and they have issued press releases on that. There's nothing that's already deployed externally, but there are some companies that are interested in deploying these algorithms. You can imagine they'd be the same people that have the technology to make these recordings or are already in the Ecg interpretation space. So once these things are FDA approved and things, we'll start to see those make their way to the commercial market, I would imagine.
All right. Another question coming in, can the predictive ECG models improve by adding baseline Icd-Coded clinical conditions rather than just age and sex?
Yeah, it probably can. I'll give you an example of that. So hypertrophic cardiomyopathy is so rare that even though the model performs well for an AUC, that's a little bit inflated because most of the ECGs are normal. So it's, that it means it doesn't have to make that many calls to still have a good AUC as long as it gets most of the true cases correct. But if you were to deploy that, the false positive rate would still be very high. So the way I think these two things come together is the AI model can identify candidates for a disease. And then we could use structured things from the chart, like is there a prior echo? Do they have symptoms? Any number of things to call that candidate list down to a smaller group of patients who then maybe we could screen or invite to come in for a physical exam or whatever it might be. So there's no doubt in my mind that the AI will be augmented, at least in the way it's deployed, by structured data coming from the chart.
And it does look like there's a few other specific questions in the chat and also some requests for contact information to maybe follow up directly on potential specific questions or just other opportunities to collaborate. And so, Dr. Noseworthy, what's the best way for individuals to get in contact with you or the team to learn more?
Just email me, lastname.firstname@mayo.edu, noseworthy.peter@mayo.edu.
Wonderful. So for those of you who have any other specific questions, I think that's a great avenue, and I'm sure there'll be more slides and content sent out. So thank you, Dr. Noseworthy. Is there any other final words you want to share with our audience before we all head out for the Friday afternoon and have a wonderful weekend?
No, have a great weekend, everybody. And thanks for your patience and sitting with me. I enjoyed speaking with you all.
Yeah. Thanks so much, Dr. Noseworthy. And thanks, everybody, for joining and attending.